Welcome to the deep dive. Today, we are undertaking one of the most crucial journeys in all of anatomy.
Oh, absolutely.
We're charting the physical support system and the fluid balance mechanisms of the brain. So we're diving deep into the cranial meninges and the ventricular system.
It's an essential dive,
Yeah.
because protecting the central nervous system, it requires this extraordinary hierarchy of physical barriers and, well, really complex fluid dynamics.
So what's our mission for the listener today? What should they be trying to build in their head?
The goal really is not just to memorize layers. It's for you to build a clear three-dimensional mental map of this architecture, from, say, the armor plate on the outside to the fluid highway on the inside.
So you can understand the critical relationships.
Exactly. And the clinical pinch points where things can go wrong.
Okay, so let's unpack the system. We'll start from the outermost layer and work our way inward with the three concentric membranes, the meninges. What are these wrappers?
Right, so moving from the skull inward, the very first layer is the dura mater.
Literally the tough mother.
The tough mother, exactly. This is the pachymeninx. It's opaque, fibrous, and just incredibly strong.
Okay, what's next?
Next is the arachnoid mater. You can picture this as a much thinner, mostly translucent kind of web-like layer. It loosely surrounds the brain, so it sort of spans across the major grooves,
And the final one is glued right on.
glued right to the surface. It follows every tiny ridge and valley. That's the pia mater transparent, microscopically thin, almost like a layer of plastic wrap.
And it's the spaces between these layers that are often more critical, right?
Absolutely. We have two key spaces. Between the dense dura and that delicate arachnoid lies the narrow subdural space.
Okay.
And then critically, between the arachnoid and the pia is the subarachnoid space. This is where the main action happens.
Because it's filled with fluid.
Yes, it's filled with cerebrospinal fluid, CSF, and this serves as a buoyant cushion, a shock absorber, and a waste clearance system for the entire central nervous system.
Let's spend some time on the dura mater because it's so much more than just a tough outer bag. It's structural.
It is structurally complex, and that's vital for clinical understanding, especially with trauma. The cranial dura is unique because it has a dual-layer nature.
Two layers?
Yep, an outer endosteal layer, which is stuck tightly to the inside of the cranial bones. It's basically the periosteum. And then there's the inner meningeal layer, which is the true protective covering for the brain.
And these layers are usually fused together except for a few key places.
Right, where they separate to form the venous sinuses, which we'll get to. But that tight adherence of the dura to the bone is what causes one of the most dangerous situations in neurotrauma.
You're talking about an extradural hematoma.
Yes, exactly. This is a true medical emergency where you get high-pressure arterial bleeding, usually from the middle meningeal artery.
Yeah.
And it happens between the outer dura and the inner skull.
And because the dura is so firmly attached, the blood has to fight its way in.
It has to forcefully strip the dura away from the bone.
Which gives it that very specific look on a scan.
Precisely. On a CT scan, that forced separation creates a biconvex or lentiform, a lens-shaped clot. It's contained because the dura's attachments stop it from spreading widely.
But that containment means the pressure builds up incredibly fast.
Incredibly fast. It compresses the brain tissue underneath. It's a high-pressure contained emergency that almost always requires immediate surgery.
Now, beyond just lining the skull, the dura also folds in on itself. It creates these internal stabilizing walls, the dural partitions.
These partitions are just brilliant biological engineering. The two most important are the falx cerebri and the tentorium cerebelli.
Okay, so the falx cerebri.
That's a huge, crescent-shaped vertical sheet. It dives down into the longitudinal fissure, acting like a divider between the left and right cerebral hemispheres. It provides tremendous side-to-side stability.
And the tentorium cerebelli is the horizontal floor, almost like a tent.
Correct. It's a horizontal sheet that separates the cranial cavity into two major compartments. You have the large supratentorial compartment above, which holds the forebrain, and the smaller infratentorial compartment below for the hindbrain.
And that tentorium is rigid. It doesn't really stretch.
Not at all. And it creates this central opening, the tentorial incisure, which the midbrain passes through.
And that incisure is the critical point of failure in cases of severe swelling, isn't it?
Precisely. If there's a huge bleed or massive edema up in the supratentorial space, the brain tissue has nowhere to go but down.
Through that opening.
Right through that fixed size opening. The tentorium doesn't give, so it shoves the sensitive brainstem and other structures through the incisure. This is brain herniation, a terrifying clinical event.
And if we're talking about pain, like headaches, why does the dura matter so much?
Because the sensory nerve endings are pretty much restricted to the dura mater and the major blood vessels. The brain tissue itself, the pia, the arachnoid, they're all insensitive.
So you can't feel the brain itself.
You can't. You feel nothing. But if you tug on the dura, you feel acute pain. It's mainly innervated by branches of the trigeminal nerve V1, V2, and V3, and some upper cervical spinal nerves.
Which explains why different headaches feel like they're in different places.
Exactly.
Okay, so now let's shift from the tough armor to the drainage system. The dural venous sinuses, these aren't like typical veins, are they?
No, they're really unique. What's fascinating is the trade-off in their design. They lie between the two dural layers, and while they're lined with endothelium, they critically lack both valves and muscular walls.
Oh, valves, that's the key.
That is the key insight. It means blood flow isn't strictly one way. Pressure changes can actually reverse the flow, which has huge implications for how infections can spread.
Okay, so let's trace the main flow, starting from the top.
Blood drains from the superficial brain surface toward the midline, into the superior sagittal sinus. This runs along the top margin of the falx cerebri.
I remember it has a distinctive triangular shape.
A triangular cross-section, yeah. And along its path, we find these little things called arachnoid granulations. They project into the sinus.
And that's where the CSF gets absorbed back into the blood.
That's the primary site, yes. Not the only site, but the primary one.
And where do all these midline sinuses end up meeting?
Posteriorly, at the confluence of the sinuses. But the flow is usually asymmetrical. The big superior sagittal sinus typically drains into the right transverse sinus.
Okay.
Meanwhile, the inferior sagittal sinus, running along the lower edge of the falx, drains into the straight sinus, which then tends to go to the left transverse sinus.
So right side handles superficial drainage, left side handles deep drainage. Then they become that S-shaped exit ramp.
That S shape is the sigmoid sinus. It continues from the transverse sinus, curves down, and eventually leads to the jugular foramen. That's where it leaves the skull and becomes the internal jugular vein.
We have to talk about the most complex crossroads of this whole system, the cavernous sinus.
Ah, yes. This one requires you to really build a mental picture. It's located on either side of the sphenoid bone.
So what's actually running through the sinus in the blood?
Right through the venous blood, you have the internal carotid artery with its sympathetic nerve plexus wrapped around it. And right beside it, also in the blood, is the delicate abducens nerve, cranial nervus 6.
So those two are basically swimming in venous blood. What about the other eye movement nerves?
They're embedded safely in the tough, protective lateral wall of the sinus. These are the oculomotor, the 3, the trochlear 4, and the ophthalmic division of the trigeminal V1.
And the clinical implication here is terrifying if an infection gets in. Cavernous sinus thrombosis.
It is life-threatening. The veins that drain the face, like the ophthalmic veins, don't have valves. So an infection from, say, the upper lip or nose can spread directly into this space.
Creating a clot.
A septic thrombosis, yeah. And it immediately compresses all those crucial nerves, 3, 4, V1, 3 eye, causing profound vision loss, paralysis of the eye, and it can spread sepsis to the whole brain.
Let's move deeper now, past the dura back to the inner layers, the leptomeninges.
Right, the arachnoid and the pia. They're connected by these fine fibers called trabeculae, which span the subarachnoid space. And remember that key distinction. The pia dips into every tiny groove, but the arachnoid bridges over them.
Which creates that crucial fluid space.
Exactly.
So let's compare trauma again. We had the high-pressure, arterial lens-shaped extradural hematoma. How is a subdural hematoma different?
It's vastly different. It happens in that potential space between the dura and the arachnoid. And it's usually from low-force trauma, like whiplash, that shears the fragile bridging veins.
So it's venous bleeding, not arterial.
Venous low pressure. It doesn't need much force to separate the dura and arachnoid. The result on a scan is a crescent shape, which can spread easily over the whole hemisphere.
Low pressure, widespread.
Precisely. And this is why they can become very large before symptoms get acute, especially in older individuals, where the brain is atrophied a bit and those veins are stretched.
Since that subarachnoid space varies in depth, where do we find the largest pools of CSF?
Those are the subarachnoid cisterns, usually at the base of the brain. The biggest and easiest to find is the cisterna magna, located just behind the medulla and below the cerebellum.
And that cistern is a key exit point for the internal system.
Correct. The cisterna magna connects directly to the internal ventricular system via the median aperture of the fourth ventricle, the foramen of Meninges.
Okay, let's now move completely inward to the ventricular system itself, the 4 interconnected spaces that are the brain's interior fluid highway.
This system is basically 4 cavities, lined with epithelium that comes straight from the embryonic neural tube. They are the factory and the initial distribution network for all that CSF.
The largest are the lateral ventricles, one in each hemisphere,
Yeah.
and they have that really distinct C shape.
That C shape is a magnificent result of development. As the cerebrum grew, it stretched and pulled the ventricle along with it, wrapping it around the deep structures like the thalamus. So you get a frontal horn, a body, an atrium, and then temporal and occipital horns.
And the CSF has to leave the lateral ventricles through a small choke point.
A tiny one, the interventricular foramen, or foramen of Monro. That connects each lateral ventricle to the central unpaired third ventricle.
Which is just a slit between the two thalami.
A narrow vertical slit. And from there, the CSF has to pass through the narrowest point of the entire system.
The cerebral aqueduct.
The aqueduct of Sylvius, yes. Yeah. A very small channel through the midbrain. This anatomical narrowing makes it the single most common site for blockages that cause obstructive hydrocephalus.
And that leads into the final ventricle.
Into the fourth ventricle, a wide, diamond-shaped cavity between the brainstem and cerebellum. And from here, the fluid finally exits into the subarachnoid space through 3 doors, the single median aperture of Meningeal and the paired lateral apertures of Luschka.
Let's talk about the fluid dynamics here. It's not just a stagnant pool of water.
Far from it. CSF is actively secreted, mainly by the choroid plexuses inside the ventricles. The total volume in an adult is only about 150 milliliters.
That's not very much.
It's not. But the brain produces around 500 milliliters every single day.
500. So the entire volume is replaced 3 to 4 times a day. That's a staggering turnover.
It is. It just speaks to the active role this fluid plays in clearance and maintenance. And that rate of production requires an equally rapid and efficient absorption system.
And finally, before we summarize, we have to mention those weird exceptions to the brain's isolation, the circumventricular organs.
Right. These are specialized midline sites where, deliberately, the blood-brain barrier is absent. They are chemical sentinels.
Like a guard post.
A guard post is a great way to put it. The most famous is the area poscrema, at the bottom of the fourth ventricle. It lacks the barrier, so it can sample the blood directly for toxins.
And that's what triggers vomiting.
Exactly. It's the brain's internal poison detector.
Okay, let's bring this entire complex system, the layers, the spaces, the fluid dynamics, back into sharp focus. What are the 2 most essential takeaways?
Well, the first is mastering that hierarchy of protection. Understanding how the rigid dura defines those contained high-pressure arterial bleeds, while the subdural space allows for the widespread low-pressure venous bleeds.
Okay, hierarchy of protection. What's number 2?
Mapping the fluid highway. Knowing that sequential flow lateral to third to fourth ventricles and identifying those critical narrow points like the aqueduct, which are potential sites for life-threatening blockages.
If we connect this back to the bigger picture, you mentioned 500 milliliters of fluid being replaced daily, absorbed by those arachnoid granulations, but you said that's not the full story.
That's the classic teaching, but it presents a persistent anatomical puzzle. If the granulations are the sole exit pathway, why do they sometimes seem insufficient, especially in infants? It raises this really important question that's still driving research. What are the other less understood pathways? Like absorption through delicate pile vessels or CSF moving along nerves into extracranial lymphatic channels. What else helps manage this massive essential fluid turnover? The brain's plumbing is still revealing its secrets.
A truly impressive architectural feat. Built-in armor, internal buttressing, and a high-speed fluid system. Thank you for joining us as we went on this deep dive into the brain's essential support structure.
Always a pleasure.
We hope you walk away with a crystal clear mental map of this neuroanatomy. We'll catch you next time for the next deep dive.